So today we will talk about the trimethoprim. First of all, we will look at the structure of the trimethoprim. Trimethoprim is basically a synthetic antibacterial agent. It has a main ring, that is pyrimidine ring. Here is the at the center you will see the presence of the pyrimidine ring. At one side you will see the presence of the two amino group. So that's why we called it diaminopyrimidine. And at the other side, you will see the presence of the 3-methoxy group attached to the phenyl, or you can say benzyl group. So ultimately, you will see the three most important component. First one is the pyrimidine ring that is present at the center of the trimethoprim. Second, you will see the presence of the two amino group. That's why we called it diamino. And at the other side, you will see the presence of the three most important trimethoxy group. Next, if we look at the mechanism of action, first of all, we will look the normal mechanism of the synthesis of the tetrahydrofolic acid inside the bacteria. Bacteria synthesize the tetrahydrofolic acid with the para-aminobenzoic acid, or you can say PABA, PABA, para-aminobenzoic acid. Next, this PABA converts into the dihydrofolic acid, or you can say dihydrofolate, with the help of the enzyme that is dihydroteruate synthase. Dihydrofolic acid converts into the tetrahydrofolic acid with the help of another enzyme that is dihydrofolate reductase. Now, tetrahydrofolic acid ultimately convert or synthesize the DNA. This is the normal mechanism of the synthesis of the DNA. But dihydroteruate synthase is blocked by the sulfonamide that we have discussed in the previous lecture. And the second enzyme, dihydrofolate reductase, is blocked by the trimethoprim. So ultimately, there will be the no synthesis of the tetrahydrofolic acid, and ultimately there will be the no synthesis of the DNA. So as you notice that sulfonamides and the trimethoprim acts on the same pathway, so it is good to use it together. So we mostly use sulfonamides along with the trimethoprims to block the whole pathway of the synthesis of the folic acid inside the bacteria. So we can use the trimethoprim along with the sulfamethoxazole, that is collectively called the core-trimoxazole. So basically, core-trimoxazole is a combination of the trimethoprims and the sulfamethoxazole, because both these antibiotics acts on the same pathway and block the synthesis of the folic acid inside the bacteria. If we look at the antibacterial spectrum, so if we look at the gram-positive bacteria, it is good for the Staphylococcus aureus, including MRSA, methicillin-resistant Staphylococcus aureus, and Streptococcus species. For gram-negative, you will see the E. coli, Escherichia coli, Klebsiella pneumoniae, and the Proteus mirabilis. Others organisms, Listeria, monocytogenes, Nocardia, and some protozoa, Toxoplasma gondii. But this is not the most specified antibacterial spectrum. It's a general one. Next is the resistance. We will look how bacteria develop resistance against the trimethoprim antibiotic. First is the enzyme alteration. As we have discussed, trimethoprim acts on the dihydrofolate reductase enzyme. So basically, enzyme is synthesized from the DNA. So DNA makes the RNA. That is the transcription process. DNA makes the RNA, messenger RNA. And from the messenger RNA, you will see synthesis of the proteins. And enzymes itself is a protein. So if there is mutations in the DNA, then there will be the modification in the protein, or you can say enzyme. In our case, that will be the dihydrofolate reductase. And ultimately, due to the mutations in the dihydrofolate reductase, the trimethoprim will not bind to that enzyme, and uh, trimethoprim cannot stop the pathway of the folic acid synthesis inside the bacteria. Our productions of the dihydrofolate reductase. So, if we look deeply, that dihydrofolate reductase, if the concentration of the enzymes increase, so now there are two substances that can bind to this enzyme. First one is the trimethoprim that actually block this enzyme, and second one is the dihydrofolate that is actually the substrate for this enzyme. If the concentration of the enzymes increase, then that enzymes can bind both of them, trimethoprim as well as dihydrofolate reductase. Even though the synthesis of the folic acid will continuous, but the concentration will reduce. Ultimately, in that case, bacteria can even survive due to the low productions of the folic acid. Bacteria will not survive or will not grow when the synthesis of the folic acid completely blocked. So little bit concentrations of the folic acid produce, and ultimately you will see the synthesis of the DNA in that case. Next is the efflux. So here is the bacteria. Bacteria continuously expels the trimethoprim from inside the body, and ultimately you will see the low concentration of the trimethoprim inside the bacteria. Next is the plasmid mediated resistance. Resistance developed due to the plasmid mediation modification. Plasmid transferred from one bacteria to another, and ultimately a lot of variants of the bacteria develops that can tackle the trimethoprim antibiotic. Next, pharmacokinetic absorption. Trimethoprim orally absorbed very well, with peak plasma concentration reached within 1 to 4 hours. Distribution: penetrate into the CSF and the tissues, widely distributed antibiotic inside our body. Metabolism: partially metabolized in the liver to inactive compounds. So metabolism happens inside the liver. Excretion: primarily excreted by the kidney through the kidney, with about 50% eliminated unchanged in the urine. So kidney function should be proper in the eliminations of the trimethoprim. Half-life in 10 to 8 to 10 hours. You will see the half concentrations of the trimethoprim, and you can see the after the 8 to 10 hours, trimethoprim starts decreasing. Next, contraindications. Those patients who face the hypersensitivity reaction to the trimethoprim or the sulfamethoxazole would not take this antibiotic. Individuals having renal or hepatic impairment will also not take this antibiotic like trimethoprim. During the pregnancy, specifically in the first trimester, due to the potential teratogenic effect. Teratogenics means it can create problem inside the body, means it can cause the abnormality inside the body. Patient with megaloblastic anemia. Actually, megaloblastic anemia happens due to the folate deficiency. So in that case, megaloblastic anemia will not take the trimethoprim. Adverse effects: GIT tract disturbance like nausea, vomiting, and diarrhea. These are the general adverse effects. Hematologic effect means megaloblastic anemia. It means that due to the deficiency of the folate. Leukopenia, thrombocytopenia means low platelets count in that case. And you can check it out with the help of the CBC report. Allergic reactions, rash, pruritus, and the or rarely Stevenson-Johnson syndrome. Hyperkalemia, high level of potassium in the blood. So due to inhibition of the renal potassium excretion, the blood potassium level increase inside the body of the patient, and other headache and the dizziness. So this is all about the trimethoprim, and we have also correlate the trimethoprim with the sulfazolamide. So if you still have any question, you may ask in the comment section. Thank you so much.